from the American Academy of Pediatrics.
63% of U.S. physicians report symptoms of burnout.
A new book from the AAP offers ways pediatricians can build resilience in themselves and the caregivers they serve.
Bringing your full self, your human self, is really what our patients want. We're sort of trained that, you don't want to be unprofessional. Well, I'm not talking about crying on your patient's shoulder, but I'm talking about being real and admitting that we're all living in the same world.
Plus, a new study looks at how suspending evictions during the pandemic affected rates of child maltreatment.
We found that the states with more generous policies for the eviction moratoria had stronger effects on the abuse and neglect prevention.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Pargabalinki. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a discussion on coaching families for resilience.
David, I just had a weekend off from work, and in the past, meaning before I had children, I would have taken these weekends to rest and recharge, maybe go out with friends, see a movie. Now, though, my weekends home involve a lot of caretaking for the tiny tenants that share my house with me.
Well, when they grow up, the caregiving does not stop, Joanna, but it does change. And it starts to go both ways, which is really enjoyable. But boy, do I remember those times when they were small. And I know you have got this. You are one of the most resilient people I know.
Oh, thank you so much for saying that. It actually means a lot. It's something I need to hear.
Well, resiliency is something all caregivers, from parents to pediatricians taking care of their patients in clinic, need to hear. Fortunately, it's also a skill that we can learn and foster.
And while I might have some resilience, I find it's also something I need to work on both at home and when I'm in the hospital. That's why I'm so glad we have Dr. Gretchen Pianka here with us today. She's the author of a new book from the AAP called Coaching Families for Resilience.
Dr. Pianka has been a practicing primary care pediatrician for 2 decades. She works with Greater Portland Health Primary Care, and she started Resilience University to foster resilience in primary care using evidence-based strategies to support positive childhood experiences. Dr. Pianka, welcome to the show.
Hi, thank you for having me.
We know that physicians, even ones with a reputation for being very bubbly and caring for children, are at risk for burnout. Do you feel comfortable sharing your experiences with professional burnout? And is that a part of the reason you wrote this book?
Yes, to both of those. So at this point, I've been practicing for, 2 decades. So it was about in like the 7th, 8th year after residency, which I think is pretty common for when people start to notice burnout symptoms. I'd gone through a divorce and I had to get a new job, and we moved, and my new job was so stressful. And I felt like I was just back in intern mode. I was going into the hospital in the middle of the night for non-breathing babies, and then showing up expected to be bright-eyed and bushy-tailed at 8 a.m. for a full day of patients. Some were double booked in 20-minute spots. And I felt like I was on that hamster wheel. And I never felt like I could really do the things that I felt like I should be doing as a mom. Like I missed everything, or I felt like I missed everything with my kids. I had a nanny I could barely afford because she had to sleep overnight because I had to be able to go into the hospital in the middle of the night. And so I just felt like I was just failing in all directions. And then I'll never forget this. I showed up, finally made it to one of my daughter's dance recitals. And I was like, okay, mom mode. And I like introduced myself to one of the other moms. And I'm like, hi, I'm Gretchen Pianka. I'm a pediatrician. And she looked at me and she said, yeah, we figured out who you were. You're the one that came in and diagnosed my daughter with strep and treated her. And you never told us your name.
Oh, no.
And I was like, oh, one of those moments where you just totally like rethink all your life choices. And I'm like, I'm just failing at this. Like the only thing I need to do now is admit it and give up and open a coffee shop. Like I can't do this. And so I came very close to, I think, throwing away my education. And then I was like, maybe I could change it kind of from the inside out. And the universe gave me an opportunity. Somebody wanted to swap positions with me who wanted to be closer to home and actually liked the inpatient work and didn't have tiny children who required a 24/7 nanny. And so I switched to a job where I could kind of pick my hours. I could walk my son to school in the morning. I could be there to read him a book at night. And I got 7 or 8 hours of sleep. And I noticed that when I felt rested, I actually showed up in exam rooms in a way I feel like I never had since I'd been in med school. I was like, hey, so nice to meet you. How can I help you? And I suddenly was like so grateful that my name was on their insurance cards. And I'm like, I'm a pediatrician. I'm like, man, I almost quit doing this. And I had so much fun. It just completely rejuvenated my love of medicine and helped me to connect with families. And then I could see like, oh, I wasn't really having fun at this before. And I don't necessarily think that they thought I was terribly useful before. Like families were asking for help with the relational stuff, with the behavior problems. And I'd say, do you have anything else I can help you with? And they'd say, well, not unless you can fix the terrible twos. And I'd laugh and say, okay, see you next time. But like in the process of developing Resilience University, I was like, oh, I see what you're asking for. You're having these relational health ruptures and you want help with repair. And let's talk about that. And what does it look like? And I started loving going to work. And now I'm like so happy. I'm so glad I didn't throw the baby out with the bathwater, but yeah, almost did.
Well, we are happy that you're doing the work you're doing. I can say from personal experience that Portland, Maine already has a great coffee shop. And you started something much more special, this Resilience University that you just mentioned. Tell us a little bit more about it. I mean, is there a campus and does it serve coffee?
So maybe someday in my dreams, there will be some sort of brick and mortar version of this. But right now, it's just summarized in the book that I wrote. And I have an online resource, resilience-university.com, where you can download absolutely everything, whether you're a parent or pediatrician, somebody who works with kids, school nurse, anybody. So you can look through the things and see what you find resonates with you and what might be useful. And then I have some online courses that are there. Everything is free. And then I've tried to summarize it in this book. And really, at its core, what I developed was a way to structure a series of visits with a family who maybe you sent them for a neuropsych evaluation and it came back really inconclusive and the family was hoping you could just put them on a pill and this would stop. And yeah, no, not so much. So it gives you an opportunity to say, okay, let me lean into this with you. Let's be curious. What's happening when Johnny hits his sister? What's happening when, Joey won't eat his dinner or whatever it is? The way I say it to parents, we're going to kind of back the bus up and figure out what is at the core of this and then how we can help shift that relational health dynamic to something that feels less adversarial and more affiliative.
So there's so many resources. I've looked at the book. Can you give us some practical steps that pediatricians can take to maintain resiliency in their practices to kind of move that needle, especially in the face of a rapidly changing public health landscape?
Totally. One of the things that I learned from this process of developing Resilience University, and that is just so important to me now, and it's just, I tell all the medical students and residents and other docs that I work with, we learn to kind of put our own needs on hold, I think often when we're in the process of learning how to be doctors. Hold this retractor until the surgery is done. And I don't care if you're tired. I don't care if you have to pee. I don't care if you're starving or you feel like you're going to faint. You're going to hold the retractor, right? And we did it. And we learned to do it and put everything like, shh, body, I don't need to respond to anything. I'm just a retractor holder. And so then somehow we kind of by default bring that along with us. And I'd gotten to this place where I think a lot of us get, where I was going into a room and all of me as a human was just shut off. And I was like, how can I help you today? Like my example, you have strep throat, here's your prescription, bye. I didn't even try to connect because I was so tired and I was so used to turning myself off that I was like, that's not even part of my job. So I think a big part of it is just learning how to synchronously care for yourself rather than trying to do this asynchronous self-care, which that was what was modeled for me. Work really hard during the week. On your weekends, you can go for a run, you can ride your bike, you can hang out with your kids, but now you're working, so just don't even think about those tiny little munchkins who you brought into this world that you love with all your heart. Just forget that they exist, And I was like, that never worked for me. I was like, I can't do this. And so I figured out how to kind of synchronously check in with my kids, be a human being, model for the next generation of physicians and, my colleagues, hopefully, that it's okay to take a call from your kid if they're having a breakdown and they need you. And it's okay to stop and pee and have a snack. And, and yes, you still can go for a run on the weekends and hang out with your family, but don't just do that. And then I do things like I'll, notice a family. I work in a clinic that has a lot of immigrants. And a family where dad is being detained and there's a new baby and mom is all of a sudden alone. And I just want to cry. I know that's not going to help, but I figured out, okay, I can feel my sadness and I can grieve with this mom. It's the affiliate response. We're in this together. We're not separate. This isn't like she's over there having that thing happen. I'm in here with you. How can I help you? What can we do? And just really using that oxytocin that we get with that stress response and trying to see us as we're in this together and how can I help you? What else can I do? And it has just been so helpful. I leave work feeling so happy that I'm here and I'm privileged to work with these families. And I just hope that it helps other people.
Well, I have to say, your resilience is contagious. We are both smiling right now just listening to you. And of course, teaching doctors to be resilient, which you'd think somebody would have told us, but as you said, it's often hammered out of us, is one job. And then we turn to patients and families, and sometimes we don't have a lot of time. How do we begin to educate patients and families about resilience and toxic stress and exemplify trauma-informed care in our practices?
So one of my favorite ways of doing this is to just, it's so easy in pediatrics. Somebody's always misbehaving, right? Somebody's always throwing a shoe across the room or stealing their sister's snack or punching their brother in the car. There's always a behavior problem. So what I've started doing is using those behavior moments to highlight for the parents or caregivers and the kids, isn't that interesting? Your nervous system all of a sudden goes kind of wonky. And so the way I start is to help people understand how to befriend your nervous system. So I'm like, whoa, so that sounds really frustrating. I'll often say, what is the hardest thing right now? And they'll say, well, every time we pick up Johnny from daycare, he hits his sister and then it goes downhill from there. And so I'll say, well, okay, so what's happening with Johnny? And he'll say, well, I didn't like the lunch, so I didn't eat. And well, what else happened? Well, I couldn't sleep last night because my sister wanted to sleep in my room and she was noisy. Well, then what else happened? Well, mom didn't let me have screen time last night, so I went to bed mad. And then you talk to the parent and you're like, okay, so by the time you're picking him up, this kid is hungry, he's tired, and he's still kind of got this angry hangover from yesterday. And then you ask the mom, well, how were you feeling when you got to pick up? Oh, we think dad might lose his job. And I was completely stressed. I wasn't sure I had enough money for gas. And so I was totally on edge. And when he, hit his sister, I was like, that's it, get out, walk home, and parents will launch into this shock and awe campaign, which comes from the fact that both mom and the kid are mutually dysregulated in that moment. So once you can kind of show them that, hey, you guys are both in saber-toothed tiger mode. You both feel as though the other person is the saber-toothed tiger and you have to protect yourself. What if you shifted that lens and you saw this as, oh, we're in this together. That saber-toothed tiger is over there, out there. We're a family and we're in this together. How can we support each other through this? And so that tiny little frame shift can be so helpful. And then focusing more on how do I take care of myself when I don't feel good versus how do I either punish my kid or for the kids, how do I not get in trouble when I'm feeling yucky? What can I do to take care of myself so I don't hurt anybody else, anything else, break my favorite toy, punch my sister in the face, say something that's going to get me grounded for a week. And that's how I usually start.
I think, if you have that behavioral in, you could definitely do that. But, David alluded to this, that general pediatric practices, they're really busy. They can be fast paced. And I can imagine pediatricians are listening to you and saying, oh, I really want to do that, but I don't know how I'm going to integrate it into what is already a very busy clinic day. Do you have any tips for how you can start to bring these topics up?
Yes. So one opportunity that we seem to be having a lot is mental health issues. So mental health issues, especially with kind of the, elementary tweens and teens. So I use this kind of language a lot because that's something that often, like say in your suicidal teenager, parents will often respond with that shock and awe fear response because it's terrifying to think that your child might be thinking that it would be better if they weren't even here. And so you can use that kind of example to say to parents, so you're in the middle of that conversation, you're deciding, you're doing your PHQ-9, you're talking about whether you're going to do counseling or crisis evaluation or medication. And in the midst of that, you can honor how scared that parent is and then how horrible that child is feeling. You can say, you guys are actually in this together. So I want to know how you can turn towards each other until we can get you in with that counselor. What if we try this? What if we try that? And that's where you can use some of the strategies in the book. And same thing goes if you're just talking about basic anticipatory guidance. Sometimes instead of starting with, is your child in the appropriate car seat? Are they doing this? Are they eating their 5 servings of fruits and vegetables? I will just stop and just say, there's a lot going on. I just want to know what's the hardest thing for you guys right now. How can I help you? And so when you start with that, sometimes you'll get, well, we're not able to make ends meet. We're ending up, running out of food. And so then you can go straight there and then you can problem solve. And no matter what I do for busy pediatricians, just remember you can break it up into little cycles of change. So that's one of my favorite little strategies is to just say, okay, let's focus on one thing. And we're going to do a tiny little PDSA cycle, plan, do, study, act. And I'm going to check in with you next week. And so you're not trying to fix everything. You're saying, okay, let's try this. Here's the stuff for that food pantry. And I want you to try this. You can go there on Tuesday at 9. And if that's not enough and you're still struggling, I'm going to check in with you next week. Or my nurse is going to call you. Or I want to see Johnny back anyway to follow up on the new medicine we're starting. So it aligns with a lot of the way the AAP wants us to stay in close contact with families who are experiencing suicidal ideation and thoughts and social drivers of health and all those things. So you can just break it down into tiny little cycles of change.
Well, I have to say this has been an incredibly enjoyable and inspiring survey course at Resilience University. Do you have any last takeaways to share with pediatricians before they read your book?
So I think one of the most important things is, I already alluded to it, but remembering that you are human and you have a nervous system. And so if you have just had a sick kid overnight, or you just heard a news statement that terrifies you about what might happen in your community or to the ones you love or something, it actually doesn't help to try to stuff it down as deep as you can and wait until later to deal with it. So that's going to take away the humanity from your day. So just remember, bringing your full self, your human self, is really what our patients want. We're sort of trained that, you don't want to be unprofessional. Well, I'm not talking about crying on your patient's shoulder, but I'm talking about being real and admitting that we're all living in the same world. And however that looks for you with whatever community you care for, just remember that patients want a human being who cares about them to take care of them. And so I always say that, what would I want if somebody was talking to me? And recognizing that our families are going through things that could be super stressful. If we distance ourselves and we stay in that kind of ivory tower mode and we're like, oh, you're over there going through that, how can I help you? That's sort of like a sympathy thing, but that true empathy of, I am right here with you, whether it's the green funny poop or whether it's we don't have enough food or whether it's a suicidal teen or a little kid who's hitting his sister, whatever it is, I'm right here with you. I've got you. I'm going to roll up my sleeves. And there's nothing you can say that doesn't belong in this room. We're going to figure it out together, just like we have when your child had asthma. So normalizing that kind of resilience coaching as though this is the same as I might be coaching you on funny poop or food sensitivities or breathing problems. It's all the same. It's all welcome.
Well, Dr. Gretchen Bianca, thank you so much for being here with us today.
Thank you for having me. This was really fun.
For more information on the book, Coaching Families for Resilience, and more, visit us at aap.org/podcast.
Coming up, we'll discuss how eviction moratoria during the COVID pandemic impacted child maltreatment. Joanna, I know you've been moving your podcast studio around in order to do some work on your house. How's that going?
Oh, it keeps going and going. I'm worried the renovation will never end, even though it's something we wanted to do. All the changes have really disrupted the kids' rhythm, and it's impacted our whole family's functioning.
Man, and you're still in your own house. Can you imagine having to leave it if your family had to be evicted from a home, leaving behind many, if not all, of your possessions?
It would be tremendously stressful, and it is for parents and for children when evictions occur. I did see there was a new study in pediatrics titled State-Based Eviction Moratoria and Child Maltreatment During the COVID-19 Pandemic. Do you think it offers some insights into the aftershocks of evictions?
I suspect it does. And to help us discover them, we have lead author Dr. Liwei Zhang, who holds a PhD in social work. Dr. Zhang is an assistant professor in the School of Social Work at the University of Georgia, where she conducts policy-relevant, community-engaged research aimed at enhancing the well-being of low-income families. Liwei, welcome.
Thank you. Happy to be here.
Liwei, I was surprised to learn from your article that in most states, a family's inability to provide stable housing is considered grounds for child neglect. Can you talk about that relationship?
Oh, yeah. So actually, in many states, a parent's inability to provide housing, especially provide stable housing, could be legally defined as a form of neglect, even if that housing instability could be driven by, poverty rather than the intentional harm. And this is very troubling in reality when you think about that. Let's say if a family couldn't support a kid with a house, with food, that child may be experiencing the risk of being separated from that family only because the parent couldn't support the kids with the material needs. And of course, when you think of the families living in poverty, there are always many interactive factors such as mental health issues, substance abuse issues related to poverty. But sometimes when families couldn't support their kids with those material needs, it is legally defined as child neglect.
So, Liwei, what happened during the COVID pandemic that provided for a natural experiment on housing stability?
Yeah, so during the COVID-19, many families have lost their jobs and they couldn't find their financial needs being met. So the policymakers, for the first time, enacted this nationwide policy called the Eviction Moratoria. Well, although it's federal level, many states did that in their own ways. For example, some states had those policy more generously, others might not be that, and some states might have a very longer term of eviction moratoria, while other states might have a shorter term. So that really provided us an opportunity to look at the differences of the policies based on those states and see how those variations could have impacted the child maltreatment rate, which is what you have just mentioned as the natural experiment.
And how did you find the state data to look at this question?
Yeah, so we were very fortunate to find this data that was created or collected by a group of scholars. They have collected this data from each state on their eviction moratoria policies and uploaded it to this public platform so every researcher could use them for free. And then we downloaded, we linked those data sets with the child abuse and neglect data that is available across the country too. And then we were able to compare the states with the policy and without and see how the policy worked to different states.
And once you accessed all this data and crunched the numbers, what was it that you found? Did eviction moratoria make any difference in child maltreatment rates?
Well, yeah. So we found that the eviction moratoria was significantly associated with child abuse and neglect, specifically for physical abuse, neglect, and sexual abuse. And also, we found that the states with more generous policies for the eviction moratoria had stronger effects on the abuse and neglect prevention.
And hearing these results, I'm impressed by how much providing stable housing alone was really able to reduce child abuse. Do you have any thoughts about the policy implications of your study?
Yeah, so to put it simple, I would say financial assistance policies, especially like the housing support policy, could be the child welfare policy. When we talk about the child welfare policy, the first thing we would think is that a child being removed from a family because the child might be experiencing risk of being abused or neglected. However, if we could support those families with food, with housing, we could probably prevent those risks and prevent the child abuse and neglect before the families even experience those crises. So I would say providing families with sustainable housing, provide families with food and material needs could be a significant next step for the child welfare policies.
Well, Dr. Zhang, I think diagnosing and treating child abuse is one of the hardest things any pediatrician can face, and I'm hopeful that this study offers insight into how we can prevent it. Before you go, do you have one takeaway for our listeners?
Yes, I do. Actually, if you look at the paper, we discussed a little bit about how the eviction moratoria actually temporarily delayed the eviction rather than stopped the eviction. That means we might be able to see that eviction moratoria delayed or reduced the risk of child abuse neglect for short term, but not on the long term. And also, eviction moratoria was rather controversial policy during that time. For the families, they were able to delay the eviction, but for the landlords, especially the small landlords, they also have seen the delay in getting the rent. Sometimes the families might be living on the rent. And what we are suggesting is that looking at the long term, having a sustainable policy, more structural, that could support both sides rather than to, put the tenants and the landlords on the tension. We need a more sustainable housing policy that could support the families on the long run.
Well, I hope this paper does affect policy. And Dr. Liwei Zhang, thank you so much for joining us today.
Thank you for having me.
To read the article, State-Based Eviction Moratoria and Child Maltreatment During the COVID-19 Pandemic, go to aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, this week I am coming back from something that was doubly pleasurable. Not only did I have an opportunity to address the Massachusetts chapter of the American Academy of Pediatrics at their meeting and listen to all the incredible things that they're doing up there in that chapter and meet so many inspiring people, but I also got a little visit in with my older son, Sellers, at the same time, just a few weeks before he graduates. So I saw some of his friends I hadn't met and a dorm room that he's about to be leaving, and just got a little more time before he embarks on the next piece of his life.
I can tell you Harvard graduation is a very fun thing. I'm excited for you when you go. My Say Ah is about my youngest, and that is that she's kind of getting to the point where she is graduating bottles. And so I bought her like a really special stainless steel water bottle. And for some reason, this felt like a milestone for me. So I wanted to share it because it's all hers. I got her name put on it and everything. It's super cute. But it does maybe mean that she's officially a toddler.
Aw, a girl's first double-walled stainless steel vacuum water bottle. It's a treasured moment for all of us, isn't it?
Absolutely.
Well, that's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll discuss medical portrayals in television and film.
We'll talk to a medical consultant on the television show The Pit, Dr. Sylvia Owusu-Ansah. I'm Dr. David Hill.
And I'm Dr. Joanna Pargavalinki. Thanks for listening.